ever before, or any accent, to be fair.
Well, you know, there's people have different kinks, and so maybe Nico's French terrain is theirs. Who knows? Unique world we live in.
Beautiful. Well, on that note, now that we are recording, I think we're going to get cracking if you guys are happy with that. I'm grateful for those of you who made the effort to join tonight. And maybe what I could do is give you literally a 1-minute introduction, just to refresh you on what we're trying to achieve tonight. And then, Paul, if you're happy with that, I'll just hand it over to you to take us through what material you've got, if that works. And then we'll have opportunities for Q&As if you guys have any questions or if anything is not super clear. So in a nutshell, basically, so you're joining the call because you're RARO members. And one of the things that we've really tried to, we've been very keen to explore for a number of years, is us as RARO members to be able to administer some level of medications to some patients when we get called out. And really the purpose of today is to actually walk us through how we're going to be able to do that for a certain number of medication. The overall concept is that either a very foolish or instead a very brave doctor, who's Paul today, is offering to basically delegate his medical ability, for lack of better words. There are better ways to do that, and Paul will explain that much better than I will. But in a nutshell, basically, what we're offering to do here is run you through what that process is like, what standing orders are like, what the purpose is, what the scope is, and then basically to walk you through the next steps so that if we get a RARO call out, you will be able to administer a certain level of medication to your patient while on scene. So this is in a nutshell really what we're trying to achieve today. Today is not the full process. Today is an introduction to the process. And then there will be some follow-up actions for all of us to do that Paul will highlight in his chat. That's probably the worst introduction I've done in a number of years, but I'll leave it here before it gets any worse. And I'll hand it over to you, Paul.
Yeah, Nico, you made it sound really hard. It's not that hard. This is going to be straightforward. It's going to take a little bit of time to get through everything, but I will rip into it. And there's definitely going to be questions at the end. If anything's burning that you can't wait, just sing out. And let's go. Here we go. PowerPoint presentation on a Thursday evening.
I don't know what you did.
And we can see it all right. Thank you.
So what we're going to cover: medical oversight, as in what is it? What is the utility? What are standing orders? Common questions I get around standing orders. Go through the drugs and talk about documentation standards and the audit process. It's not as bad as it sounds. So what is medical oversight of SAR? It's basically the non-direct involvement of a doctor in a SAR team. So i.e. me being part of your SAR team and this is not me coming in and telling you guys what to do. You're all well trained, you're all FEC level trained, you all know exactly what you do, you're experts in rescue. I'm not telling you how to do that at all. I am a resource. Use me as a resource. Ask me questions, say, you know, I've got a patient with this, or we're going to a patient with this, what are the things I need to look out for? Or we had a mission the other day, this kind of thing happens, why did this happen when I did this? That kind of thing. So I'm gonna be as I say, provide medical knowledge. So a resource, definitely not telling you how to do stuff. And what I give to you guys can be what you want. I can come down, I can do trainings with you. The doctors can be part of
get out with Sue or something today.
What's that?
Yeah. I don't organize anything.
Hey, Tanya and Stu, maybe if you guys can just mute yourself just for the presentation. No worries, guys.
Sure. It was meant to be.
Thanks.
Alrighty, so it doesn't mean doctors can't be a part of the team. I'm not going to be on call for you guys. I live between 2 and 3 hours away. It would be ridiculous. But if you get a doctor involved in a SAR team, they should have some knowledge about the environments that you guys are operating in. Otherwise, you get some, and there has been in the past, particularly the Taranaki guys did have some particularly interesting advice given about continuing resus, and that was futile and pointless in the horrific conditions, putting a SAR team at risk. So what can I do for you? I can provide you standing orders. I can review, revise, and create protocols as we need. I can give telephone advice. I can come down and give you training and help partake in some. I can debrief operations. And if you guys get any complaints from people, then from the medical stuff, I can help say, well, actually, no, you guys are doing right. And I can take that off your back as basically being your medical go-to person to defend any things of what you were doing. So why me? I've been a doctor now 20 years. I train in urgent care, which I think is probably, that and ED are probably the most appropriate for SAR. I've got specialist wilderness medicine training. I've got a fellowship in wilderness medicine. I've got a diploma of mountain medicine, which is a UIAA and ICAR recognized qualification, which is a mix of technical rescue training and kind of theoretical knowledge. So basically practical. And if you see the picture, there's me on a twin tension race on our simulated rescue in Canada, where I was there training. I've been up Taranaki a bunch and the Ruapehu a few times, and I am on call for Hamilton Landsar, and I'm a team leader for them. So standing orders, what's that all about? Well, there's a bunch of laws which govern this, but I'm not one fancy speak, but the actual quote is at the bottom there. But what is it in English? It basically means that you are prescribing medicines on my behalf because I'm not there. Okay, so in New Zealand, the only people who can prescribe are doctors and dentists. Everyone else who gives you medications on that is on behalf of a doctor or a dentist. So if you see a nurse practitioner, there will be a doctor behind them signing them off. If a paramedic's giving you some medicines, there is a doctor somewhere signing that off. It basically means you have to follow a set of guidelines of when you can't give certain pills. You need to document what you do, and that needs to be audited, and you need to be certified by doing some kind of test. That in English is the summary of all of that. What are we going to be giving you? Straightforward stuff. Paracetamol, ibuprofen, you know that for that. Salbutamol, that's the blue inhaler, and those are for people who are known asthmatics. Sometimes you find hysterical young ladies who feel like they can't breathe. They've never been told they're asthmatic in their life, but they want an inhaler because they've seen their friends with them. Those people will get worse if you give them salbutamol. Don't give it to them. Ondansetron is a very powerful anti-sickness medication, and the reason it's great is you don't actually have to swallow it or inject it. It comes in these little oral dispersible things, which you literally just crunch up in your mouth, and it gets absorbed through your tongue and your lips. It's awesome. Takes about half an hour to work, but if you're going to be bouncing someone down a slope in a litter, it's going to stop them from throwing up and making a mess that you have to clean up. Adrenaline for anaphylaxis, all know that. Loratadine is basically a hay fever pill. It's good for people having straightforward allergic reactions, itchy skins, or even if they've just got a bit of hay fever and it's making them a bit off. And aspirin for those people you think might be having a heart attack. And Penthrox is methoxyfluorine, is the green whistle that you see the AMBOs given. That's the good stuff. And so we'll talk about that. So what training do you need to be able to give that? As part of being RARO, I assume you are all FEC level trained as most ACR. So you'll be able to get everything in this. And what you need, something like this lecture or me coming down and talking to you to complete a quiz, and then you are good to go. So at the end, I will drop a link to the quiz. You can do that. And then tomorrow, if you get a shout, you can be giving any of these meds if you've got access to them. And we'll talk about access to meds later. So you can go to Camden and buy paracetamol. Why do you need training and all this palaver to give it to someone that you meet on the side of the hill? Well, the law for this is actually a little bit grey. I've tried to get some clarification, tried to find the actual kind of data for this, and it's unclear. There's no test cases, and all the legal people that do my kind of medical defense couldn't give me an answer. There are classes of medication, so you can buy paracetamol and brufen off the shelf. I think loratadine's an over-the-counter medication. There are scripts, stuff you can only get when a doctor has prescribed it, and there are controlled drugs like morphine. And the difference between a prescription and a controlled drug is the controlled drugs are very rigorously controlled as to who they go to and when they were given, and they have to be locked in a special cabinet and things like that. So you could say that if you were carrying paracetamol and brufen on your person, even something like loratadine, and you gave it to a person, would that be illegal? And like, probably not. But you're taking on the responsibility for giving that medication. And should you give that medication and then something bad happen, even if it's nothing to do with the medication, there will still be questions asked. The benefit of having a standing order is I take on all that responsibility off your shoulders. And has there been any cases? Well, this case is in Christchurch of a guy who was an EMT who had some adrenaline vials for when he was running a street clinic for homeless in Christchurch, and he got arrested. Now, with all of these things, there's a little bit more than meets the eye, and I know a paramedic down in Christchurch, and this guy's a slightly special character who was also arrested and charged with impersonating police officers. So it's an interesting case, and there might be more to it than meets the eye. But there has been this that's happened. He never actually got charged. What I don't want to happen is to you guys is you have any grief about giving medications. I want to take all that stuff off you so you can practice within the clear guidelines and do good for your patients without the worry. Do you have to give medications? Are you obliged to, both legally or ethically? If you are uncertain, the answer to that is quite clearly no. So if you listen to all of this and go, I'm not so sure about that, I don't want to do it, let no one tell you you should have given them pills. If they do, you send them to me and I'll have a word to them and we'll sort that out. You don't have to give any of these medications if you are unsure. And I'd rather you didn't give stuff if you were unsure than did give stuff and ran into grief. What about females that are pregnant? So most of this is fine. So paracetamol, safe as houses, rock on, as is loratadine. Ibuprofen, if they're in their first and third trimesters, there's a tiny risk. You can ask the patient if they want to have it based on there's a tiny risk depending on how sore they are. Salbutamol, again, that's the blue inhaler, fine. Aspirin, no. Ondansetron, no. Would say tiny risk of cleft palate. It basically increases the risk from fuck all to slightly more than fuck all. Now, my children, their mother had ondansetron through both of their pregnancies and they are just fine. And I was happy with that based on the risk. I happily give someone with severe vomiting from pregnancy ondansetron, but you have to let them know that if they take this, there is a tiny, tiny risk it's going to cause them problems. But the risk is tiny, and the risk of them vomiting, and if they're in a litter obstructing the airway, is probably a far greater problem. Penthrox, the green whistle, again, tiny, tiny risk of first trimester. So use with caution, but if they're so badly injured that they're needing it, then use it. Because they're probably going to the stress and pain and all those chemicals that you release when you've broken your leg is probably going to do more harm. But again, it's an opportunity, you can discuss it with the patient, but if they've got a broken tibia, they'll be taking it. Is there an interaction between the meds? Yes, if you give them repeatedly, but your standing orders for one-off doses. If you give lots of salbutamol and ondansetron, it can cause you issues, but that's the only one. Everything else you can give together, no problems. Paracetamol, simple pain relief, 2 tablets. They're 500 milligrams. You can't really buy it in any other doses. 2 tablets for an adult, taken orally, little sip of water. It's excreted by the liver. The main contraindications for that is people with liver issues and people who are allergic to it or have had problems with it before. All the patients you're going to be giving medications to need to be alert and orientated so you can ask them questions. If someone's not alert and orientated, you can't take a decent history of them to know whether they've got any allergies. You shouldn't be giving them meds. That's one of the key points. So if someone's got a reduced level of consciousness as well, you're not too sure about what they're doing with the airways, so trying to get them to swallow stuff is hazardous as well. Ibuprofen, again, straightforward, same stuff you give off the get from Countdown. Again, 2 tablets, 200 milligrams is the normal dose. You can get 400 milligram tablets somewhere. I haven't seen them in New Zealand. I've definitely seen them overseas. Good for pain. If someone's sick with a fever as well, good for that. Not for patients with kidney problems. Now, some asthmatics do get wheezy with anti-inflammatories. So if they're known to get wheezy with any anti-inflammatories, avoid it. You're probably not going to run into too much grief, but it's another problem you don't need to deal with. So give them paracetamol in that stage. So it's about 1 in 6 asthmatics will suffer from getting wheezy with ibuprofen. And as it's such a common drug, most asthmatics will know about that. Salbutamol, the blue inhaler. It's basically the drug acts on the airways that are spasming in asthmatics to release them. You use a spacer, and I'll try and get you some spacers with the inhalers as well. To use it, it makes it far more effective. It's about 4 to 5 more times effective using the spacer, because you don't have to synchronize your breaths with the inhaler, and also even with the best synchronization, you basically line the back of your throat with the drug. So using a spacer mixes it in the air better. It gets down into the lungs where it does its goodness. It will give people a racing heart. That's pretty normal. And don't give it to people with really bad thyroid problems. You won't know if they've got a low potassium unless they tell you, and they're known to have it. And if people get funny heart rhythms, you probably want to avoid it. But it's a risk-benefit thing. If you're worried about it, get on a call to me or St. John's and say, this is what the patient's like. Should I give it? If they're really short of breath and they're having an asthma attack, you're probably going to err on the side of giving it. If they're only a little bit short of breath and you can deal with it, then you might avoid it if they've got any of these problems. So the dose is between 2 and 6 puffs, and between every puff you give 6 breaths. So it's like puff, breathe in and out 6 times, puff. And you can do that up to 6. So if someone's really short of breath and really struggling and really wheezy, give them 6 puffs. Let's go. The amount you have to give before you cause grief is massive. So don't be too stressed about giving this stuff if the person's asthmatic. As I said before, if you have a 20-year-old lady who's having a panic attack, who feels like she had tight chest and she's never been diagnosed asthmatic, do not give her this. It will make her worse. And that's one of the things we had at Sound Splash. We had lots of young ladies coming and going, oh, I can't breathe, and they're clearly having a panic attack. Like that. This will make you worse. That's all pretty straightforward so far, team. We're all happy so far. Not going too quickly.
That's good from my end. Thank you.
Cool. I don't think we need to go into like what the drugs look like in the kind of the far things and stuff. So on Danstron, now, great drug for nausea. Works in both on your gut and on your brain. It's 1 tablet every 8 hours. You can give 2 if you need. If after half an hour one's not working well, give a second one, and it's dissolved in the mouth. So you literally just put it in their teeth. They can crunch it up in their teeth, and it works really well. It's a great anti-sickness. Does have a funny taste to it. It's meant to be strawberry, but yeah. Good luck interpreting strawberry out of that. So just tell them there will be a funny aftertaste. The main problem with ondansetron is people with long QT syndrome. Now that's basically a wiring problem in the heart. Now people will either know about that, or they will have a history of young people, like young sudden deaths. So people in their teens or 20s, like running out onto a soccer field and dying. So ask them if there's any long QT in the family, and if they look at you strangely, like any history of young sudden death. And obviously things like car crashes don't exclude it, just people who basically drop dead. Yeah, so there we go. Long QT. So it's an inherited rhythm disorder, generally runs in families. Some meds can cause it. The main problem with ondansetron is its interactions. So the following, if you remember these are fine. So your normal anti-hay fever and the pill, that's what most young people might be taking. When I looked at what interactions were, this is the first 5 pages in small font of all the drugs that interact with ondansetron. And that's why I didn't write a list of all the other things. If people are on other meds, phone it in and say, is this okay to give them ondansetron with? Because otherwise this is just the first 5 pages and it went on for many more pages. There's so many interactions, just check. Things like antidepressants are common and they interact. So yeah, if they're not taking any pills, great, give it. If they're taking a normal hay fever pill or the oral contraceptive pill, give it. Any other meds, call it in. Nico.
Just a quick question for me, or clarification here, is about the I guess the use of ondansetron and why you would want to give someone ondansetron. The way I usually approach that medication is, if I see that we're going to be transporting, for instance, the patient, and in a way where it might be that we know that the person is nauseous, for instance, and that or there is a potential for that, and that we know that it might be difficult to manage the airways, so that could be long trip in helicopter or litter, etc. This is usually my approach. Is I say, okay, the potential here of that person basically vomiting and compromising airways in a position where I may not be able to manage those airways. This is usually a good trigger for me. How does it sound, or what's your take on that?
So, like, if you are needing to do a technical raise or lower, managing an airway in that situation is particularly challenging. And the same if you're going to be winching up in a helicopter, and like you can have people in a lateral position in a litter and winch them. It's not ideal. We try and avoid that. So if you can, someone you've given some ethoxy to get them into the litter and package and they're feeling a bit queasy, yeah, give them some. If you're going to be on a long litter carry out, because for whatever reason, and it's going to be bumpy, for sure. If they're getting sick, give them some ondansetron. It's a pretty safe drug. We give it out every day at my work, every day, without worry. So just check about that history of sudden death and drug interactions, and if you're good there, you're golden. It's really safe. The worst side effect of it is constipation.
Yeah, which is not your problem on the day, it's tomorrow's problem.
It's not you guys' problem either. And in fact, you probably would rather they were constipated for the time that they're with you. It just saves a lot of problems. So yeah.
Thanks, Paul.
Yeah, I'd like, as long as you don't have any of the contraindications, give it. I'm happy to supply you with as much of this stuff as you need. Because yeah, having someone vomit in the middle of a raise or a lower would be not that great. Right, so moving on. Adrenaline. Adrenaline has one role in life, and that is for anaphylaxis. There is no other treatment to anaphylaxis. There is one treatment, it is adrenaline. What is anaphylaxis? Essentially, it's a life-threatening, catastrophic cascade of your immune system. Basically, everything's letting go. And the way you diagnose it is you need 2 or more systems of your body. And the systems are like skin, so you get a rash all over. Your GI, you get a good gut ache. Your throat and tongue may swell, that's angioedema. You get chest wheeze, or you get hypertension. And that's basically the way, if you're not taking blood pressures, you try and stand on someone up and they fall over because they faint. So if you've got someone who's got a funny rash and you stand them up and they're just getting all lightheaded and wanting to lie down straight away, they've got anaphylaxis. The dose is 0.5 ml into the outer thigh. And you repeat that as much as you need until they are not exhibiting the behaviors. Don't give it to anyone who's not in anaphylaxis. If someone's in anaphylaxis, they are potentially dying. so you've got nothing to lose. If someone's not in anaphylaxis, you can precipitate strokes, heart attacks, and other tachyarrhythmias of the heart. It's not cool. But if someone's in anaphylaxis, this is the drug they need. Now, the chances are of you finding someone in anaphylaxis and you having to walk in to get them and them still being alive is low. But this might be useful for your team members as you walk in and someone gets stung by a bee or something. Or the other thing is you've given someone a drug and they've reacted to it. So these are your instances where you might find it useful. If your team members do have an anaphylaxis of things, then perhaps they should have their own EpiPen. But that's something you should be discussing more with them and their GP. Antihistamines and prednisones can ward off. So some people start with an allergy type thing, and then it progresses to anaphylaxis. Some people disagree with that doesn't happen. It either is anaphylaxis or not. Yeah, for the purpose of this is anaphylaxis. Give them adrenaline. Repeat the dose after 5 minutes if they're not getting better, until you run out of adrenaline, basically. How do you give adrenaline? Well, here you go. This is a 3 ml syringe. The reason why you give 3 ml syringes, it's much easier to draw up. You have a drawing up needle, not necessary 100%, but it's got a little filter in it so you don't get glass ampules in it, and you've got a blue needle, and that goes through most people, clothing, whatever. You can get into most people, the upper outer thigh. And if you want, you can clean the skin with a syringe if you can get there. If someone's dying, don't worry about that. Infections are last thing on your mind. We can give them antibiotics, just give them adrenaline. There we go. So if you ever see an ampule, which you should get hold of some, I'll get some down to you guys. There's a little white dot on it. You push on the white dot, it breaks easily. It's useful to wrap it with something, some kind of cloth, your t-shirt, your jacket, whatever, just so if it does shatter, you don't get glass in your finger. Anyone who's been used to popping ampules in healthcare and has done it for more than a few years will have cut their finger at some point. So now most people just wrap like their t-shirt or their shirt or something around it. It just protects you from there. You draw up what you need, grab a handful of thigh, hold it like a dart, stab it in, squeeze and hold. So grab, stab, squeeze, and then draw up your second dose. Because firstly, then it won't get lost, but also then you're ready to go. And you can practice on an orange, is said to be the thing that is meant to most represent giving an iron injection. And there is me demonstrating. Then get rid of your sharps. Don't stab other people with it. So moving on, loratadine, it's 1 pill, 10 milligram tablet, and it's basically for itchy, hay fever type, straightforward allergy stuff. It's safe as houses. Go for your life. 1 pill. There's no point giving a second pill. It won't change anything. And the amount you'd have to give to cause any bad would be like packets of it. And then we'd have to have a talk around while you're doing that. It's not for anaphylaxis. It's not going to help you. They need adrenaline. I can't emphasize that enough. It's adrenaline is the treatment for anaphylaxis. There is no other treatment. Aspirin, these are for people who usually have known cardiac disease. They'll feel like someone's sitting on their chest. The pain can radiate up to their jaw, down their chest, down their arm, into their back. They usually look sweaty, pale, and look like they're in imminent danger of their demise. You give them 1 pill, they chew it. It's not going to do anything for their symptoms. However, the evidence is quite clear. It has massive survival benefits. It tastes awful. And I don't know why the cardiologists insist on people chew it. I think it's because it gets into the system better once it's chewed up and trying to get a bit through your tongue and your teeth, your lips, a bit like the ondansetron. Don't give it to pregnant people. If someone's severely bashed up from trauma, then you probably should avoid it. If you're not too sure it's definitely heart and they're on blood thinners, probably avoid it. However, one pill of aspirin and blood thinners is not going to be the end of the world. If you read the literature and say it's contraindicated, yeah, one dose is going to be fine. Moving on to the fun stuff. Green whistle. It's a fantastic drug. The reason why it's fantastic is it's super stable in the environment. It works really well. It's short acting. It wears off quickly, and there's minimal side effects. The main use for you guys is when you find someone and they look very out of shape, is for you to make them look like a person and get them into a litter. You've only got about 20-25 minutes of constant use out of it, so you're not going to be able to use it for your entire carry out, but you can get into someone into a litter without them making your eardrums bleed. There is one hitch. It is otherwise super safe, except in the elderly, other than if you have this genetic thing called malignant hyperpyrexia, which, if you're on the beginning of the call, we talk about this. There's a group. I think I've got a slide about this, so I'll move on. If you give someone Penthrox or methoxyfluorine, they must either go to a hospital or urgent care, never discharge them home. If they're that badly in pain that they need the green whistle, they need to be going and getting checked out. Now, whether that's ED, a local urgent care, a GP that's open, your choice, but you need to hand them off to someone. You can't say go home and see how you go. So malignant hyperpyrexia or malignant hypothermia or MH, it's a severe life-threatening reaction to volatile anesthetics. So basically anesthetics that turn into gas. The key sign is someone's jaw, usually its jaw will start twitching and start tensing up. And so they'll notice it's twitching, and then they'll get a really high fever, their heart will start to race, and they'll get progressively more unwell as essentially they cook themselves. What happens is the anesthetic triggers all their muscles to twitch and overreact, and that produces heat, which eventually cooks them and they die from that. And so the mainstay of treatment, if they do get that, is mainly cooling. There are drugs that you have in hospital for it and stuff, but they're nowhere near you guys, so don't worry about those. But your treatment is to stop any of the medication and get them as cool as possible. That's the only way that you're going to help these people. It's pretty rare. However, it is pretty local to you guys. Palmerston North is the New Zealand capital for malignant hyperpyrexia. If you're in Christchurch and you've come from this family, and it was a seal trapper, a Dutch seal trapper that brought it to New Zealand in the early 1900s. And now there's about 1,500 people, and they all descend from this one guy. They all generally know who they are and whether they have it. They're very good at educating their own family. And so the only people who might not know it, if it's a child on a camp, but usually by the time the children are old enough, they're aware of it, that they've got problems with anesthetics. All the adults that I've met with it are really well versed, and they usually go and get a muscle biopsy in Palmerston North Hospital, is the only place in New Zealand you can do it, where they test it to check whether they've got this gene thing. So it's pretty good. They should be able to let you know. This is Penthrox device. A lot of you will have seen these. That's what it's made of. It's basically got a polypropylene wick. There's a charcoal thing. I like to use that so you don't spread this stuff around. If you're out on the hill, you don't need to use this at all because it's going to get distributed. What you do is if you want to attach the charcoal, which again, if you're in an enclosed place, you probably want to use that. You can use the bottom of the dispenser to twist off the thing, turn it upside down, pour the good stuff down the tube while you twist it around, and then wrap it around your patient. There's a little band that's on the end. You wrap that around their wrist, give it to them, and tell them to suck on the end. There is a tube, a little hole at the top, and if you want to make it stronger, you basically push on the hole, or the patient does. if you're doing something, so say they've got a very badly bent leg and you want to straighten it to get them into the litter. So you'll get them going on the normal stuff, and then you'll get them to cover the hole, and they'll be high as a kite. You can get them straight. The standard dose is 1 of the ampules. You can give a second one if you need it, but 2 ampules is your dose for 24 hours. Make sure you ask about malignant hyperpyrexia. I can't emphasize that enough. If you get someone with malignant hyperpyrexia from this, you are in a really bad situation that the patient may well not survive from. And that's because of something that we've given them. So that's why I really need to emphasize that. Always ask about the malignant hyperpyrexia, problems with anesthetics. But they might say, oh yeah, my auntie had one and she vomited a lot. Yeah, that's sweet. It's this allergic reaction thing we're going for. I think we've covered all that. Last 20 to 25 minutes. If you use it intermittently, so you get them going on it, they're comfortable, and then you're sorting your gear out and getting stuff ready, they can be off it, and then you can kind of wean the use of it as you need it. And as I say, you can give a second one if you need it, and then that's your lot. By the time that you've given a second one, they should be way off somewhere else. Once you've used it, into a Ziploc bag, into your normal garbage. Storage of stuff. Medicines, usually I say keep them in a Ziploc bag or one of those Systema click-clack things. Try not to cook them. Penthrox comes in its own little packet, and I have mine in a Ziploc bag just to keep that safe as well. The salbutamol inhaler can be stored inside the spacer, and I just suggest write either on the inhaler or something in Sharpie the expiration date, so when you're going through your kit it's super easy to check. And the same with your other meds. If you have a bit of paper on the front of your first aid kit with your name of your meds and the expiration date, when you're doing your kind of however often you guys do your own gear checks, your monthly gear check, whatever, you can look at that and go, yeah, it's not November yet, we're still good. And that's just an easy way to make sure your meds don't expire, and that you've got enough. So documentation. What do I need from you guys to make sure that I can audit you and make sure you're giving it correctly, basically, because that's what I'm required to do. How you record your documentation, I leave up to you, and how you get it to me. Anyway, you can email me just a quick little email saying, yeah, Paul, we had a 25-year-old lady, these are her details, broke her leg, I gave her some methoxy, and these are dates and times and the indications of what happened to her. Done. You can write out your little Lansar notepad and then take a picture of that and WhatsApp it to me. Anything works as long as you report. Send me some documentation to say you've given it. We're good. Doing that sooner on the mission is better. All notes, whenever you document notes for patient care, doing them as soon as possible within reason to when you're doing it is always better, because your detail is better, then it's more accurate. What do we need? I need to be able to identify the patient. Obviously, this stuff will be kept confidential. There's no doubt about that, okay? Name, date of birth, contact number. What happened to them? As in, fell off some rocks, broke leg. Sweet. Fell while climbing, hit head. That kind of stuff. Useful thing is to have a guess at how high they fell. And this is all good for your records should untoward things happen and become a coroner's case. This is the kind of stuff I'd expect you should be documenting anyway when you're going out to a call, just because if things happen down the line, you will be expected to be able to record this knowledge. Everything else is there as it is. Past medical history, what problems they've had in the past, what medications they take, what allergies they have. Document nil if they have none. So that if you don't document anything, you haven't asked it. If you say past medical histories none, that means you've asked it and they've said they've got none. Nico.
So all this documentation is something that, sorry, I'm directing that comment to everyone else but you, Paul. Just for your information, so all this kind of documentation is something we have to work out on how we do that best. I think the way it's looking, in my view, is that we will actually come up with forms which are very simple to form and that we will attach to any medication basically in any of the packs, so that it's super easy for everyone. It's a good prompt for the questions to ask and what information to record, and that can then just be snapped easily and conveyed to Paul or to the committee, and we can forward it immediately. So in other words, don't feel like you have to remember all those details. We will make sure that those details are clear, are really clear to record, and we give you the tools to do so.
There is a LANSAR PRF or patient reporting form as well. That's already done by LANSAR with all of this stuff on it. And it's got way more stuff than I need. Lots of pictures and stuff to draw on as well. It's very much like the St. John one. But there is one done already, so you don't need to reinvent the wheel there. So it's already okay.
100%, thank you.
With the Penthrox and ondansetron, you must record whether that you've asked them about malignant hyperpyrexia. And there's just some tips and things to ask about problems with anesthetics or allergic reactions to anesthetics. If someone does have it, if one of their friends or the other members in the party has got malignant hyperexia, you don't want to have them near the person chucking on the Penthrox, because you might make another patient. It is really that powerful. So if like your patient's on Penthrox and you're lifting a group of 2 people into a heli and one of them's got MH, they'll be doing badly by the time they land. So yeah, just be careful around other people around Penthrox as well. And obviously you need to ask questions about long QT and unexplained death in ondansetron. Exam, brief focus, this will be on your form as well. It's always useful to record when, how much and how you gave the medication. And I find, this is just general LANSAR stuff from me, I find it's always useful to have on your notes when you were deployed, when you got to the patient, when you applied a splint, when you decided to call for a heli, all that kind of stuff. I document that all on my own notes when I go out on a call. And I think that's useful stuff for you to have there as well. Is your hands up again, Nico, or are you?
Yeah, just a quick one, basically, or quick comment on the Penthrox. The what you mentioned, which is crucial to make sure that we also cognizant of people around the patient when we give Penthrox. I think we can also extend it to RARO members who might have actually that condition as well. So I think it's something that we need to check as well.
You do have one who's got it in the family, so you've got to be aware of this if you're going to be using Penthrox. And I'm not trying to put you off using Penthrox. No, it's probably the best drug I'm giving you, and the most useful drug that I'm giving you, because most of the time you don't have someone with a mild headache. Like, you do walk some people out who are just not having a good time, but most of the time you're going to someone who's had a significant injury, which is why they're still on the hill. You just have to be a little bit careful with it around that one pesky thing that is going to be worse for your group than any other group in the country, other than people around Palmerston North. But and no other ACR group is going to have to worry about this as much as you guys do. Audit requirements, ideally within a week, sooner the better. However you like, really, as long as you can get it to me, email, WhatsApp, picture. And if you have any worries about any of these things or any questions or queries, sing out, ask. My role and what I want to be for you guys is a resource, someone to ask and to support you guys in the work you do. That's kind of my thing. It's like, I'm not going to tell you do things wrong. If you can do stuff better, I might point you in the right directions. But if you have questions or queries, sing out. If you guys want me to come down and do training on things like hypothermia wraps and splinting, all that kind of stuff, happy to come down. I've got some Penthrox trainers as well. And if you want me to come play in some technical rescue, I love it. So I'll be keen to come and do some of that. I can rig a little bit. I'm no expert, but I can rig a little bit. Any questions from you guys?
I've got a couple of points, or maybe to add as well, or maybe a slight question. But before I get there, I'm just keen to see whether anybody else has any questions or any thoughts from you guys on the call.
I totally appreciate that I've just thrown a whole lot of stuff at you. You know, we've been going for 50 minutes and I've covered a whole lot of stuff. So, like, I've kept it pretty simple because I don't think it needs to be hard.
Yep. So I'll get cracking with a couple of maybe a comment and then a question. So the comment is about the Penthrox, about the methoxy. So the current plan that we've agreed on with the RARO committee is to store all the other medications that we talked about, with the exception of Penthrox. But what we thought would be worth doing, and for a number of reasons, one is the potential contraindications and I guess the slight difficulty around the region because of the sensitivity around MH. The other one is just a cost issue. So there are a number of considerations we've taken into account. That being said, we were keen for everyone to be signed off for that, because we also recognize that through RAL, some of you are from RAL, but also if we had a call out where we had access to RAL medication, there is Penthrox out there, and it would be silly not to actually, I guess, train everyone or make sure that everybody is able to administer Penthrox when appropriate, if Penthrox was made available. So we're working with Anna from RAL on that point there. But for all intents and purposes, at the moment at least, initially, don't expect Penthrox to be available in the immediate medical kits. So just a bit of a clarification there. The second one is more a question for you, Paul, and we can take some of that conversation offline, is around the level of training that you would be requiring for people to be able to use the standing orders. We do have quite a nice mix of people in RARO. Some people are members of RAL, some others are members of St. John Peak Safety, and all those guys are based, if I'm not mistaken, have a requirement through their employments to be FEC trained, and to be not only FEC trained, but to be FEC current. There are a number of other organizations. We also have some individual members who are not necessarily part of those organizations. And we also have Hillary outdoors, and I'm not entirely au fait with the requirements in terms of FEC and currency of FEC for Hillary. So I guess the question for me is, there are some RARO members which are very easy from your point of view because everybody is FEC current in many ways. We do have some people who are not necessarily falling in that camp. And the question to you, I suppose, is how you would like to go about those guys, whether it's by aiming at getting those guys FEC trained, which is one of the options. The other option is whether there is any alternative we could use to either administer a subset of those medications, or to actually do some form of competency so that you get the comfort and the assurance that you need that those guys are able to administer those medications.
Yeah, that's pretty straightforward. If you have a first aid certificate or more, you can get paracetamol, ibuprofen, and then the standing orders say FEC or equivalent. So Lansar now have advanced outdoor, which I believe is meant to be kind of a FEC equivalent. If you're an EMT, I'd say that would be a FEC equivalent for me. And if you have any higher qualifications than that, that's again, you're covered. The other thing that I don't think I covered is the scope of the standing orders. And that's one of the key things where the RAL people might have been unwittingly running into some problems. The RAL standing orders that you guys run only work when you're doing stuff for RAL. And the reason I know that is I've got a copy of them and I've read them. These standing orders I'm providing you is for only for Lansar jobs. Now, That doesn't mean if you're on a, doing something with some friends, and you've got stuff with you, can you give it? Well, you can give it off your own back, but you're not. This is not a RARO thing anymore. If you want to give it under a standing order, you can just give me a call. As long as you've got some kind of communication to me, I can verbally approve you to give stuff under the standing order and the equivalents, and I will back that up. So if you guys who are used to these standing orders want to do other things that aren't necessarily RARO, then get in touch and we'll talk about that. That's not really part of that. Just be aware that when you are not on a RARO job, which comes from the police, essentially, police Landstar RARO is the mission, then these standing orders do not cover you.
So I've got a really good example of that, for instance, as an example. So once I was just having a bit of a run around Tongariro, for instance, and then I stumbled upon a bunch of people, and one of the guys was in distress. I was not being mandated by the police as a RARO member. I was just a bystander, basically, who basically just came upon. So I called 111, dealt with that situation separately, but I was not there as a RARO member, which means that I would not have automatically fallen under this standing order. Likewise, if I'm getting called as a RARO, I'm putting my St. John hat out, my peak safety hat out, and a number of hats I've got, and I'm falling straight under RARO under this particular standing order under Paul's. So it's something that we will do. There is a bit of an education piece for us to do internally within RARO, just to make sure everybody is crystal clear on that, and that whenever we've got jobs, it's crystal clear that people are deployed under RARO, so that then you put your RARO hat on and you fall under what Paul has been presenting tonight.
Yeah, there are ways around it with simple stuff. You could, like, I don't think there is going to be a problem if you say, here's 2 paracetamols, I'm going to put them there, you can have them if you want. You're not going to get into legal trouble for that. Where you turn up and say, I'm a member of Ruhr Power Alpine Rescue Team, here are some meds to take for your problem, that can be interpreted in I would say, in an extreme situation as prescribing, and that might lead you into some grief. But if you give people to say, I've got some stuff, you can take it if you want, when you're not under RARO, sweet. That's a way around it that you can get yourself. Then they're taking it off their own, just like them picking it off the shelf at Ganther.
Yep. Awesome.
Prescribed meds, you might have some more trouble with if that goes awry. Anyway.
Yep.
Team, do you have any questions? I love questions.
No questions from me per se, just some really good points that Nico brought up, kind of stuff that we need to discuss as a team for mainly us newer members that aren't Ski Patrol, aren't Hillary. So we'll talk about that stuff at a later date.
Yeah, 100%. And maybe one question we could be asking is the next steps from here. I can speak on behalf of the committee in terms of how we're going to be moving forward, but maybe first from your standpoint, Paul, just to actually, for everyone to really understand what the next steps are from this point onwards.
So people need to read the standing orders. They're on a Google Drive. They're not that interesting. They shouldn't take too long to flick through. There's no real quirks in there, but you should have read what you're signing up for, because essentially this is kind of a legal document you're working under, and if you don't follow it, you're kind of on your own, and you kind of don't want to be. And then when you've read them, you do a really hard quiz. It's not hard. And then that will get emailed me through, and as long as you get everything right. If you don't, then I'll just email you back and go, well, this is your thing. If everything's badly wrong, we'll have a bit more of a discussion, but you should be fine. None of this is hard stuff. It's just based on what we've done. There are some other resources which, as I've added more meds, I need to adapt. So what I gave Taranaki is a little meds cheat sheet with all the medications and the doses and the contraindications written on. I need to improve that because it was only a few meds back then, but people have asked me to add more. So I will improve that. I got it printed out on little waterproof cards that were, I think that's A6 sized, so very easy to stick in a pocket. And I also need to get some meds down to you guys. So things like if you did your quiz right after this, and then tomorrow you got a call, you can go and give them countdown, get a countdown and get some loratadine and not loratadine, ibuprofen, paracetamol. And if you take loratadine anyway, you can take that with you. You can give those. Like seriously, so you've done the quiz, you passed it, you can give them from that moment. The only problem is going to be access to other stuff, and I'll work with Nico to get some down to you. My weekends have just got a lot freer because the mountain's shutting and there's no snow, so I'm not going to be coming down again snowboarding. So might be doing some touring soon though, because there's still some snow back up front.
Just a quick comment from me, Nico. Have we got Paul's contact details?
Yeah, so I've got. So what we will do there, Tony, thanks Paul for dropping them there. What we will do is after this, maybe not tonight, but over the next few days, we'll send a wrap-up email to the whole RARO and highlighting the different basically points that we covered tonight, especially the next steps. And there is a bit of a piece of work that we need to do in terms of getting medications, in terms of having the medical kits and the forms ready as well, and also the conversation that we need to have in terms of training as FEC as well. So there are a number of things we probably need to do, but we'll circulate an email to everyone so that everybody knows what the next steps are. The only thing I will need from you, Paul, in addition to what you've provided already at this stage, is perhaps the link to the YouTube video when you've got it. So I'll wait to have that, and then we can put it on. Already.
Yep.
Beautiful. Awesome.
I thought that Lansar wanted all Alpine rescue teams to be FEC trained.
I think it's still very much a work in progress in many ways. So I think we still need to. That hence my question and how we actually close those loops around those. Yeah.
If any of you guys do have questions, seriously, shoot me an email, flick me a message. Happy to chat. And if you're going out to jobs and you've got questions, just seriously, happy to provide advice. And also keen to come down and do some training with you guys, so you know who I am and what I'm about.
Awesome.
Yeah, I think that sounds like a good next step as well. Is just to get you down when we have one of our trainings. Obviously, Witten training is gonna wane at this stage, but we'll be doing some training around rock skills, etc. as well. So there will be heaps of opportunities, and very keen to have you there. And maybe one of the things as well that we've been thinking about and we're doing step by step is maybe also starting to progressively inject a little bit more medical scenarios to some of the trainings we're doing. Right now, it's very much focused on the technical rescue side of things, which is awesome. I guess at the end of the day, most of the people we go and rescue are also patients. And I think this is an opportunity for us to grow as a team and for you guys to grow as individuals in terms of growing the skill set in terms of patient care, etc. So I think this is kind of the next step, and the standing orders are almost a natural first step in that space.
Yeah, and just remember, use me as a resource.
Exactly.
I'm here for you guys, so.
Yeah. Awesome. Any final questions or comments from anybody else before we wrap up? I'll take this as a no, as people are hungry if you haven't eaten already. Awesome. So I mean, first and foremost, thanks to everyone for joining in tonight, and for those of you who are looking at that as well on YouTube and after the fact. And more importantly, or just as importantly, thank you, Paul, for being our doctor for the standing orders. This is really kind of, as I said earlier, is a bit of a step change in terms of what RARO can do with our patients on the mountain. And thanks for taking the time as well to join us at 7 p.m. on a Thursday. Much appreciated, mate.
All good. Have a good